Welcome everyone to today's webinar, How to Future-Proof Nursing, Leaders Weigh In on Tech, Flexibility, and Workforce Wellness. Before we begin, I'm going to walk through a few housekeeping instructions. We'll start today's webinar with a presentation, and there will be time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. If at any time you have any trouble with the video or audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm excited to pass the floor over to Curtis Anderson, Chief Executive Officer at Nursa, to kick off today's discussion.
Brilliant. Thank you, Maddie. And thanks to everyone for joining. We've got a great discussion ahead of us. As Maddie mentioned, I'm the CEO and founder of Nursa, a contingent staffing platform that helps connect the manager who has a short-term shift need with the lowest cost, reliable nurse who can fill that need. And as we jump into the discussion today, I'd love to take just a couple of minutes. Sheila, Mark, and Katie, all of you have such a diverse set of perspectives on this topic, and I've watched you work. I admire the work that you do. Could we just express or share a little bit of background before we dive into the first question? And Sheila, why don't you kick us off with that?
Sure. I'm Sheila Kempf. I'm an ICU nurse at heart. I've been a nurse for over 40 years. I've been a nurse exec for the past 20 years. I've been a chief nursing officer of a small community hospital, large academic medical center. My last position was as a CNO at Penn Medicine Princeton Health, and I've been actually doing interim assignments since that time. And I love talking about this topic.
Brilliant. Thanks, Sheila. Mark?
Oh, good day, everyone. I'm Mark Smith. I lead a function in human resources for a health system on the West Coast related to people analytics, workforce optimization, staffing. Staffing includes recruiting, contingent workforce management, and learning and development. I've been in healthcare for 21 years. Prior to this role, I was a chief human resources officer, working side by side with great chief nursing officers like Sheila and finance leaders to really make sure that we were being responsible in the way that we staff so that we could meet the needs of the communities that we serve.
Brilliant. Thank you, Mark. And to round us out today, Katie.
Hello, I am Katie Rose, a nurse by background with over 20 years of healthcare experience. The last 7 years I've spent focusing on workforce optimization. In my previous role, I was a system vice president of workforce optimization here in the Midwest at a large healthcare system, and I am currently a senior director in healthcare at Huron Consulting Group.
Brilliant. Thank you, Katie. And thanks to each of you for being here. As I mentioned, I think the work that you're doing is incredibly respectable and in many cases pushing the boundaries forward as we think about what changes continue to affect the nursing workforce and how nursing is incorporated into the broader conversation of patient care. Just to get into it fairly quickly, the role of nurses, we talk about it a lot, continues to change. There's certainly an evolution here in healthcare. I'm interested to just kind of zoom in as we start to annotate or to speak a little bit about the differences that you're seeing in the workforce and in the macro environment today versus something as near term as just a couple of years ago throughout the pandemic. Sheila, do you want to kick off some thoughts there?
Sure. I think during the pandemic, nursing really rose to the top of their experiences and their value in our healthcare society. I think the innovation that we saw during COVID, nurses did what they needed to do. They innovated unbelievably and quickly. And I think that really set the tone. Today, we have a number of different situations. We have a healthcare nursing shortage. We have nurses who are still reeling from some of the effects of COVID. And so well-being has become a major topic. But I think that nurses today are demanding a lot more from us. They want more flexibility. They want a better work-life balance. They want to work on their terms. There's a lot more opportunity available for nurses today because there is such a shortage. We've redefined many of the roles. that nurses play today. New jobs are emerging, new roles are emerging, and I think the opportunity for nursing is terrific in terms of what they can do and where they can go. It is a challenge for administration to deal with all these different facets going on. And so I think we are challenged as nurse leaders and administration to really understand the staff needs, the patient needs, and what we can do to balance both, obviously within the financial limitations that we now have. So I think it's really a huge opportunity for nursing to find different ways of fulfilling what they want to do with patient care.
It's a fascinating set of notes. I mean, Mark, you've been pretty deep on this as well in the way that you're approaching the dynamism between the pandemic and now. What are some of the updates that you're seeing or things that you're learning this year?
To add to what Sheila mentioned, what I'm seeing emerge more and more is what our nurses are looking for twofold. First is predictability. And so as we think about flexibility, there also has to be a predictability to it. Sheila, as you mentioned, what our nurses did over the course of the pandemic was heroic. There's just no way to say it otherwise. And it created burden. We still have nurses recovering from everything that occurred during the pandemic. So flexibility is a word that I really appreciate, and it has to be predictable. And as I look at some of the data in recruiting today, in our health system, I was looking just this morning, we have over 500 posted requisitions for per diem, role type, and variable shift, which really means that from a health system perspective, we'd like you to be available anytime, anywhere, any day. And what we're seeing from our nurses is they're living their lives, and there needs to be some type of reliability to what is available. I can tell you that with those 500 open roles, we'll likely fill them. We'll fill them in about 90 days or less, and over 50% of those roles filled will be open again in about 90 days. So we haven't met the predictability metric for our nursing caregivers. And from a financial perspective, that rolling cost per hire just becomes something that is daunting. I think the other thing that we're seeing in the marketplace and nurses is a desire for the health systems to be creative. So even as simple as posting a per diem position that is reliably either a day, night, or evening helps with flexibility. It's a little bit creative in the way that we think about it. Looking at different models of care, I think we're seeing an emergence of the use of virtual nursing, which provides support at the bedside. It opens up different skill mix opportunities. I think we're seeing more reintroduction of the LPN and the LVN, more use of certified nursing assistants. That virtual nurse role creates a new level of opportunity and creative way to work. And finally, we're seeing these new models work beyond traditional per diem of really like thinking about more marketplace. And so how do we think about an on-demand workforce that sees many shifts open and really identifies with those that make the most sense for them? So again, I would really emphasize predictability is really important, and being creative in the way that we staff is also very important.
Yeah, it's an interesting note, Mark, to what you're saying and to what Sheila has spoken about. We recently did a survey of more than 2,000 nurses across the country. 72% of them had a full-time job, but also took a side per diem, would do per diem work as well. There's some interesting notes in that it generally feels like we're moving towards the flexibility. We're also getting a shift in the industry, or seeing a shift in the industry where this idea of creative solutioning feels more like an investment, both in energy, effort, and in fiscal resources, as compared to the pandemic, where as soon as we were out of the pandemic, everyone felt like this was just the absolute enemy, the idea of thinking about this creatively. And the focus was so much more acutely on hiring full-time, with no other exceptions to that. I think those are interesting shifts. And the idea of flexibility, this isn't the first exposure that we as an industry have had to that. We've been talking about nurse flexibility for a good long time. I think in some sense, what's exciting for us to see is that there is now tools and mechanisms by which we can test and creatively throttle how we're thinking about that. When it comes to managing the workforce and thinking about this dynamic, you also talked about predictability. There's a predictability component that's certainly helpful financially, but there's also some facet of this that just goes back to simple dynamics, nurse-patient ratios, and being able to understand what the patient flow would look like in predictability, and then balancing that for organizational, with the idea of being an organizational steward. You've got these three pieces where we need to be good financial stewards. We want to provide, the best patient care, and we want to provide flexibility for the nurses. I'm curious how each of you are balancing those three, and how you look at prioritization when you think about that. Katie, you have some thoughts you want to share there?
Absolutely. A few items that we're seeing really across the country being developed is really flexible PRN programs. And so providing that flexibility for the workforce to decide how many hours they really want to commit to a week, a pay period, schedule period, and really diversifying recruitment pipelines as well as a part of that workforce planning. So ultimately opening up those additional pipelines, as Mark was talking about, all of those open roles that they currently have, and how are we recruiting to those roles, and what are the appropriate mix that we would like to recruit for those roles, are a few of the items of the flexibility that we're seeing within the nursing workforce that health systems are working through currently.
Brilliant. Yeah, Sheila, you've had a couple of experiences with this in the near term as well. What are you seeing?
So I think, we all talk about nursing flexibility, which obviously we'd like to provide. There are nurses who would love to do 4 hours. There were nurses who would love to do 8, 12. I actually met someone want to do 16 hours, 2 days a week, and that's it. So, balancing their needs with the needs of the patient is our biggest challenge. Staff who want to do 4 hours, if you had 3 4-hour nurses in a 12-hour shift, I've actually had a patient ask me if someone didn't like them because they had 3 different nurses in a 4-hour period. So we have to really figure out how to balance productivity and flexibility with patient needs, because we really, if you have 3 handoffs in 12 hours, that reeks of a problem that's going to happen. You're going to have mistakes. You're going to miss something. And the patient flow of care is going to be compromised. So I think having to figure out, when you want to work a 4-hour shift, what's the role that you work? Is it that you do a full patient assignment, or do you become a discharge nurse or an admission nurse or a virtual nurse? Or are there other roles that nurses can do to help their fellow nurses who take a full patient assignment, so that we're not compromising patient care, patient experience, and we're allowing the nurse to be flexible? So I think that balance is what we need to strive for. We really, having one solution, a finance solution or a nurse engagement solution or a patient experience solution, is not going to work. It's got to be a combination of all 3 groups working together to see how do we manage this and how do we provide the best experience, and not just experience, but safe care. Patient experience is important, obviously, but safe care is all equally important. And so I think we need to figure out how to balance those 3 objectives, so that we can really provide the highest level of nursing care, safe, with a good patient experience.
It's a good call. It's a great call out, Sheila. And I think, as you're pointing out, it's incumbent on us to continue to look at where we can meet somewhere in the middle. Love your call out. For example, a nurse who desires to work 4 hours on a shift might be best served in a different role. If it's at the bedside, it might be break, meal relief. Yep. So that we are helping the rest of our care team. And to that point as well, thinking about how we create a connection over the course of a day for the patient with an emerging opportunity like a co-caring or a virtual nurse model, knowing that there will be someone there who serves as a bridge throughout the course of the day. The patient knows that while not in the bed, not at the bedside, in the room to attend to needs and to help direct care becomes critical. So we can continue to find those ways, as you mentioned, starting with what makes the most sense for the patient. I really believe if we start with what makes the most sense for the patient, we'll unlock what makes the most sense for our nurses and for our bottom line. But really starting with the patient in mind for our design should lead us to better opportunities and options for our nurses, and really for the financial stability of our health systems.
Yeah, these are great call outs. We start to see in that same survey data, the supermajority cite, almost 80% cite that flexibility is part of the pursuit and why they even evaluate per diem as an opportunity to work. Half of those are looking to either advance their degree or are the main breadwinner in their home. And so there's a bunch of contextual considerations that go into how they're thinking about it. On one hand, when we optimize too much for flexibility, we can impact patient care. And I think, Sheila, in what you're saying, there's also an element of context matters. The unit and where this is at. Mark, you're certainly certifying that as well in the comments that you shared. Flexibility unlocks a certain number of nurses who can fill those needs and gives us access to a portion of the workforce that we might not otherwise have visibility to. As you each approach the staffing requirements of your organizations or with the functions that you're filling across a variety of organizations, what do you use as guidelines to ensure you don't get overly focused on a financial piece, on a patient care piece, or a flexibility part of the conversation? Sheila, do you have thoughts there?
Sure. I think key for me is involving the staff, right? The people on the ground, the people who touch the patients every day, live the life every day, are the ones who can come up with solutions. I've had a situation where, a hospital brings in a financial productivity consultant, and that's all they do. And so they come in and they set up hours per patient day, and this is the staffing you have to have. And what happens is the nurse managers fight them all the way. And then you have a real contentious environment that eventually does not work. But if you involve the nurse leaders, the nurse directors, the nurse managers, and the staff nurses in the solution, you will find solutions. Nurses are very inventive. They are very smart and they are very inventive. If I went to a staff nurse committee and a committee of nurse managers and said, this is the amount of money we need to save, right? Everyone has their bucket. Everybody has their goal. This is nursing's goal. What can we do? How can we do it? And you will be shocked to see how many great examples come out of that. And I think that's a very important factor here. One of the things I think we need to do is educate nurse leaders, directors, nurse managers on finance in a hospital. That no money, no mission is true. We have to do it. It is part of our responsibility. And so the more you educate them on how the interplay works and what's important, how value-based purchasing works, how incentives with insurance companies work, how mix matters, how length of stay matters. When they understand all those intricacies of finance, they can really help us find solutions for staffing and meeting the objectives of the hospital. If you try to isolate that, it just doesn't work. It has to be a multidisciplinary solution, working with HR on recruitment. And Mark, you've mentioned this before, predictability, but really recruitment and how fast can you get people in the door? How fast can we onboard them? So that there's nobody to point fingers at. Everybody's in the same room with the same objective. How do we staff appropriately? How do we use the correct person? Is it overtime with a bonus? Is it a per diem, outside per diem, who can come in on demand? Is it a traveler? What is it that is going to make the situation actually solve the situation? You can bring in temporary help for a unit who goes in crisis, help to stabilize that unit. You can do that and then move them out. But hospitals that say, okay, we're just going to get rid of travelers or we're going to get rid of on demand, it does not work. There's a time and a place for everything. And you just have to use it in moderation and figure out the financial implications of the staffing model that you want. Virtual nursing works great. Does that mean we get rid of ratios? All right. What are we taking away from those nurses? Is it time that they actually spent on things, or is it things that they, you know, I hate to say it, but a lot of times some of the things that goes by the wayside is the discharge. All right. I have to get this patient out the door. I'm going to teach really fast. So does a virtual nurse really help that? Or is it something that they weren't doing to begin with? Right. So I think we need to understand how everybody works together to achieve the objective. Education is key. The amount of nurse leadership, and Katie, you probably see this more than I do, the amount of nurse leadership who don't understand finance, and I don't mean the CNO, I mean the nurse directors and the nurse managers who don't understand finance is really amazing to me. But I think if we helped educate them, they would be part of the solution and not part of the problem. And they'd work with us and we'd be able to solve a lot of these problems. And particularly staff meetings, staff shared governance. I think still bringing things down to the staff level. I've had units when you put it out to them, the units have said, oh, we want an admission nurse. We're a telemetry unit and we get admissions all evening long from the emergency room. How can we help us? They decided they wanted an admission nurse. We figured out how to do it and they thought that was the best thing ever, right? So each unit, it really can solve a lot of their own problems and meet the financial objectives of the organization.
It's a great comment, Sheila. I had growing up, a gentleman who lived down the street who was older and would say to us as kids, "Is 50 miles an hour fast?" And then you'd answer, and he would respond and say, it depends. Is it in a school zone or is it on a freeway? And in this place, when you educate, what you're talking about is educating the administrative, the managerial team to help them understand how to be good organizational stewards, and then empower and enable them to make decisions as a team and with the managers in tow. The context of each specific unit matters a great deal, and that nuance is part of how you can celebrate and use the right tool for the right job at the right time. Mark, this is something that your organization has been acutely focused on, especially the division that you lead with Providence. What has been your experience, and how do you set guidelines in your work today?
Key for us in the work that I'm doing is making sure that we can provide insights and options. Sheila, to your point, we really believe that our role is to enable the nurse leaders to make their best decisions. And so making sure that we have the right data so that the nurse leader can make a decision, to know that there are multiple ways to solve for it. We leave that to the nurse leader. We've also found key is really working intentionally to integrate it, to bring it together. So if I'm providing insights in 5 places, I haven't actually solved anything for the nurse leader. So we've worked to make sure that our contingent workforce investment really sits in one platform with a variety of options, whether that's a 13-week rotation, it's an on-demand rotation, a permanent placement decision. And I'm sure over time we'll consider other options, but based on the insights that we have, the nurse leader knows that there's a place to go to activate, particularly when we think about our contingent workforce investment. And I do think that's the key. We think of contingent workforce as an investment. And it's a great option for our nurse leaders, but we trust them based on the information that we can provide to make that best decision. I would even add, as we work with our nursing leaders in providing staffing forecasts, we trust the leaders to make a decision based on the staffing forecast, not to take the staffing forecast as Bible. I can't tell you in the moment whether or not we're in a heavier season in an ICU where we know that we're going to have more patients requiring intubation and extubation. I might have data that tells me we think it typically happens around 9:30, but I don't know what's going to happen today at 9:30. So we have to trust the nurse leader, and we have to make sure that we're creating options that are viable and make sense. So that's really been our focus: right insights, right options, and then the third is really making sure that there's one place to go. We don't want the reward for creating a new solution to be another place. We heard loudly and clearly from our nurse leaders in 2021 when we looked at simplifying work that on a typical day in our organization, a nurse leader might go to 30 different platforms. So I'm really conscientious that I don't want the reward to be the 30-second platform.
I think for us, we're seeing more integrated solution projects, just really leading from what Sheila and Mark are saying here. And we're seeing that we're moving to a more balanced approach in really evaluating the overall total cost basis of labor. So it's not just one piece or the other, from staffing to finance, HR. It's really all parties are coming together, sitting at the table and making the decision. Historically, I believe that we all saw the squeezing of the balloon approach, where we would squeeze one side and then it would balloon to the other, and we'd have to bring in agency, or then we'd squeeze that side and then we would have vacancies and we'd have staff turnover, have retention problems. And so really we're seeing big consulting firms coming in and being pretty busy with large health systems to try to help solve some of these foundational problems, such as the productivity, skill mix, workforce planning, and evaluating how can we build those talent pipelines that I earlier discussed, from GNs, international nurses, experienced RNs, and what's the right mix for the department to ensure that we're providing that quality of care, that we have the right people, right place, right time, and assessing that contingent labor and ensuring that there is going to be those use cases for it. So let's build it into the budget. Let's ensure that it's a part of our workforce planning, and just ensure that we're using the appropriate resources at the appropriate time.
Yeah, it's a great call out, Katie. I think one of the pieces for me, and I've seen this in each of your work, so much of what you're doing is optimizing for flow efficiency rather than resource efficiency. And what I mean by that, every discussion about staff is a people-led discussion, and every discussion is headed towards some version of recruiting. All of these, and where we see fractures across the industry, these examples, Sheila and Katie, you both called this out. Mark, I know you've seen it as well, where you get this whipsaw effect of contingent not as an investment, but as the enemy. Anyone from outside, where that is handled in a supply chain capacity, or not in tandem with an HR or a people team dynamic, you lose out on the benefits of just serendipity, of people who like working with you that would have come through the door otherwise. But you also have a tendency to then focus so heavily on the cost. And what starts to disappear in that is contingent expensive? Certainly, under one perspective, just like the 50-mile-an-hour question. But when we start to calculate costs of turnover, costs of burnout, impact to patient care, the cost of the opportunity cost of beds that go unfilled or that can't be filled, the dynamics change quite significantly, and your perspective starts to widen. This idea of seeking balance, and so often the pursuit of that balance is just about keeping a number of spinning plates up at once, and none of those plates will. Two of them will never be spinning at the same RPMs, but what you get is the ability to focus on which plate is next, and continue to dial it in with these integrated solutions across the board. We see a huge amount of success, and it's part of why for us as a platform, we don't charge higher away fees. We're not looking to interrupt that serendipity. So much of the value as a partner that we can play is to be a test driving partner for both parties, to find short-term relationships that have long-term engagements. Better than 25% of the people on Nursa today have taken a position, go on to take a position after filling per diem shifts with the partner that they filled those shifts with. And so we know that this produces committed relationships, and that in seeking balance, we're overall better at delivering patient care. Embracing technology or using the right tool at the right time, it continues to feel like an essential part of where the industry will go and what lies ahead. What barriers are you seeing to integrations? What challenges have you experienced, and how did you respond to them? Mark, in this case, could we start with you?
Yes. When we started on our on-demand journey, we thought of it as a separate work stream. And so we introduced the notion, we provided tools, and we had it separate from everything. The upside was we saw really great results from on-demand, so we continue to have that as a lever in our overall contingent workforce investment. And at the same time, we probably limited some of the use because it was a totally different workflow and a totally different work stream. So when we came together, nursing, human resources, and contracting to develop a strategy to really manage and provide resources for our contingent workforce investments, we decided that the approach would be to think about marketplace and to really create a platform where the components of contingent would reside. So 13, as I mentioned before, 13-week resides as a component in the platform. On-demand resides as a component in the platform, as does permanent placement. What it did for us then, it actually made integration much easier. We had to integrate within a platform rather than creating a workaround. So we're seeing continued really good use. When we started in on-demand, we were seeing that our nurses coming in were probably picking up in advance 5 or 6 shifts in a month, which was fantastic. And we saw growth this year as we've moved it into an integration. We're actually seeing even more movement. We're seeing over 5,100 shifts being filled using on-demand, in part because it's easy for the nurse leader to activate that if they so desire. We're not going to a separate place. So to your question, Curtis, you can't underestimate integration. And with the right partnership, many things can happen. I think for all of us, Sheila, you can probably attest to it. It wasn't that long ago that if your triad really was nursing, human resources, and finance, it's really now it's really 4 corners: nursing with human resources, with finance, and with IT, because the technology has to flow in support. It can't be fragmented. And so I think that's one of our key learns. The barrier to on-demand, I think in some respects, isn't whether or not health systems are ready for it. It's whether or not we can integrate it. And that's why bringing IT into the conversation as early as possible becomes key to really unlocking on-demand, if it's an option that you want to consider, to really seeing it work to its fullest.
Right. That, Mark, that's a really good point. I had forgotten the IT component, because my next thought here is that I want to address 2 different things. One is, how does the nurse supervisor make a decision when she needs to fill a shift for tonight, tomorrow, the next day? And what kind of data can we provide them on demand? How can we integrate it into our systems? So if I'm looking at a shift, do I hire it overtime? Do I hire overtime with bonus? Do I hire an on-demand contingent workforce? What do I do? And so having that data to know who's on what, if I look at my shift sheets, very practical, tactical. If I look at my sheets, who is doing overtime? Who is not doing overtime? Who's going to go into overtime? And having all that data very quickly so that they can utilize the best resource possible, financially speaking, right? So I think that's really important. And you're right, IT is an integral part of this. It has to be part of your whole system, your scheduling system, everything. The contingent workforce has to have access to your schedule, so that if I know I have holes coming up, how do I get them filled? And how do I open it up? Do I open it up for full-time staff first? Do I open it up to my own per diem staff? And then how do I open up with sequence? And I think data is important for that. The second thing I did want to comment on when implementing a contingent workforce. So I've been in situations where we just bringing them on. I was at one hospital where they demanded exclusivity, which sounded like a good idea to the contract people, right? It sounded like a great idea. I'm going to work with this company and I'm going to demand exclusivity so no other hospital can take my staff, my contingent staff that I want to hire, so they're ready for me. And what you find really quickly is that the pool of nurses is very small, because they have no place else to work but your place. And unless you truly are a big system or a big academic medical center where you can fill all those shifts, you don't have enough work to be exclusive. So I'm a very opinion of the, float all boats. And so opening it up to numerous hospitals so that people want to work in that area, people want to do contingent staffing so that they can select where they want to go when the need is there. Having said that, you need to make sure that your hospital is the place everybody wants to come. So you need to make sure that your hospital is the one that's receptive to the contingent workforce coming in, that provides a good orientation for them, that welcomes them in. And that if given a choice of 5 hospitals, each nurse will say, oh, I want to go to that one because they treat me better. I like working there, right? So that it puts the onus on you to make sure your reception of this contingent workforce is good. But it's a trap that people would fall into. And if you leave that in contracting hands, they'll say we have to have exclusive, but when you really play it out, it's not a good plan. So I did want to get that point across for those of you who are thinking about implementing a contingent workforce on demand, because it's an important factor.
It's a great note, Sheila. Katie, you've seen this across a handful of implementations. What would you add here?
I really think that Sheila and Mark covered it. You have to ensure that the system integrates into your scheduling system, your time and attendance, or we're just creating more work for our own internal managers, HR team, payroll, etc. And really then with productivity is impacted from a financial standpoint because those hours could not be factored in. And so really looking at and ensuring that we're not creating fragmented data processes, workflows that then just exacerbates the resistance to change. And because that's what we see is that we bring in this new system, we're very excited about it, we work on our change management, however, it falls flat. And the reason that they typically fall flat or it's not successful is because we don't do all of those steps to ensure that we're actually creating a better workflow and making life easier for the nurse managers instead of more challenging by creating those data disparities and creating items in silos. And now they have to work in 4 or 5 systems to really then have the full picture of what is their staffing for tonight and what is their need. The other item is creating really those foundational items that we would think all health systems have in place, but just as Sheila spoke to about what is the hierarchy of bringing staff in. So who do we open shifts up to and when do we open those shifts up and at what price? And so ensuring that we're really taking that holistic approach and ensuring that we're bringing in the lowest cost labor, as well as supporting our internal workforce. And so allowing them that first chance to pick up that shift prior to bringing in that on-demand workforce individual. So we don't create any of those cultural rubs because really we want them to be our partners and we want it to be collaborative between all of our parties that are helping support our, patient care.
Yeah, so these are great notes, and we certainly see similar pillars in how we can set this up. In the best cases, certainly getting rid of exclusivity. So the idea of being free range is really helpful and does lift all boats. We have data that can show that, Sheila, in a market that as we loosen up some of those contractual obligations and strings and working with the right partner, no exclusivity certainly feeds everyone in a market. The other aspect is as we release and make decisions in a hierarchy, one of the most beneficial things that we do with partners today is have them post that job as early as they can to a contingent layer. Send it to Nursa early. There's no obligation, no cost to post, no obligation to fill it with us. And what we find is that gives the nurse manager information that they need at the time that they need it. So as they're going through this hierarchy of decisions, they don't have just descriptive data about what the weather is like and the likelihood that they can fill this externally, but they know exactly who is interested in filling it for them. So when they're comparing options, in an overtime scenario versus sending it to Nursa versus doing something longer term, they have all the information for the full length of the decision-making timeline. We also, in having these discussions, there's also a note about pushing nurses or helping enable nurses to practice at the top of their license. In some sense, it feels like what we're opening up is we're opening up discussions about being more of a generalist than a specialist here, but I don't think that's true in all cases. For each of you, how do you incorporate that into your thinking about moving nurses to the ability to practice at the top of their license while we're managing for some of these other guidelines and pillars that we've discussed in the models that you're implementing? And Katie, would you have thoughts to share on this first, on this one?
So I'm going to go to like the innovative care model. Everybody likes to talk about innovative care models, as that's really kind of some of those buzzwords that we're hearing out there in industry right now. We don't really have a definition of what is an innovative care model and what do they look like? Are they successful? Are they not? And so really we know we have to transform and we have to rethink traditional healthcare delivery to improve patient outcomes, to ensure that we have the appropriate staff member at the right time to support our patient care. But I think that we have to go back and look at those foundational items again of what do we need to do to support in care models, and what type of training do we need to have for our providers, our care providers, to be able to be more generalist, to be able to float to different units to help support a whole hospital instead of just a specific unit or delivery of care within a certain ICU or progressive care unit. And so really it's working through collaboration of those, nursing departments, leaders, and having the conversations with frontline staff that are interested in this and developing education programs and ensuring that we're looking at our interdisciplinary teams and ensuring that the nurses are going to have the support that they need to really move into a different care model. I don't think that we've solved all of those problems yet to be able to do that.
Yeah, I agree, Katie. I think there's a lot of different things about this, and there's many different conflicting factors going on right now. We have publications and literature that talks about ratios, BSN nurses, and how this decreases mortality, increases safety, and there's a lot of body of literature around that. And then you have a lot of legislation trying to move towards ratios and those kinds of things. And if we don't have the nurses to do that, then we need to figure out another way. The question for me is, what are the nurses doing? And this goes to the top of license question. What are the nurses doing that someone else could do so that maybe a nurse could take 5 patients or 6 patients because they're not spending their time doing things that are not, a nursing license is not required. For instance, there's a lot of literature that we spend sometimes 40% of our time hunting and pecking, looking for equipment, running down to pharmacy, going to blood bank, those kinds of things, transporting a patient outside. Could we take those things away from nurses and then they could increase their ratio safely and provide nursing care because someone else is doing the other work? And I'm not sure we've explored that enough to see how that happens. There's a lot of LPN models people are suggesting. Now, I learned way back when, team nursing. We had a nurse, we had an LPN, we had an aide, and we took a group of patients and we did that. So when people talk about innovative care models, I laugh because that's where I came from. That's what we all learned when we were in nursing school. So I think that we really need to look again at each unit. Each unit is going to be different. But the key to me is involving the staff in that decision. If you sit down with a group of nurses on a unit and you say, what are the things you do? And we've actually done this. You sat down with nurses and say, tell me what you do that you don't think you need to do, that someone else could pick up from you. How much of their workload could you move to somebody else? And then how can we craft that unit? Maybe it's a tech person. Maybe it's someone who just takes care of equipment, right? It could be all different kinds of things. But I think we have a large opportunity to really look at how do we give safe patient care in a reasonable way that the nurse is able to give the nursing care that they want to give in the manner they want to give it. And not just say, okay, it's just 4 patients or 5 patients or those kinds of things. But how do we use the evidence in the literature to design what our innovative care model looks like? and how do we involve staff in that process? So I think it's a combination of a lot of things. And again, I think we've all commented on, there's not one solution. There's many different solutions depending on where you work.
I think it's a great call out, Sheila. And I think what you're saying, and Katie, I think you did as well. At the core, before we can be innovative, we have to be brilliant at the basics. So how do we ensure that we are providing the level of care that we desire? How do we understand and augment the nurse so that the nurse can provide direct patient care? Innovation is going to look many ways, but starting by being brilliant at the basics, making sure that we have a care model that makes sense for the unit, makes sense for the ministry will be important. As you mentioned, Sheila, we saw an age where we had a rise in LPN and LVNs, and then we had confusion about how to manage the license, and we saw a decline. And today, with different treatments, we're seeing a rise again in LPN and LVNs, which is fantastic. With different approaches, we're seeing a rise again in use of certified nursing assistants. And future state is probably even a little bit more creating even more delineation within a certified nursing assistant role. Caitlin, as you mentioned, there are many things that a CNA does that can be done without a certification. And is that a nursing assistant? Is it a unlicensed bedside assistant? We can think about that, but in any event, what it becomes is a new pathway. And I think that's part of what we have to think about is the outcome of the innovative approaches has to be to preserve the talent that we have today while thinking about creating pathways to encourage talent in the future. So if we can break a certified nursing role into something that looks like an unlicensed bedside assistant, I am able to provide patient support under the direction of the nurse. I hopefully will get excited about bedside care, think about a pipeline into a CNA role, get excited there, and with the right resources and tools within the health system, think about becoming a nurse. Our health system has talked a lot about how we create pathways, 6 figures in 6 years. And I really think that it starts by being brilliant at the basics and being and really taking a closer look at roles near the bedside that could be split, that provide avenues to provide care now, and hopefully to get excited about bedside and nursing careers in the future.
Sounds great.
These are great comments. I think one of the things that we see as well on this idea of mastering the basics, and maybe one note of reflection that I've always found interesting in the space as well, we tend to educate with the perspective of getting someone to the NCLEX, which is a general test. And then immediately after they accomplish that, we push them towards a career where practicing as a specialist or moving towards top of license is the focal point. And I just think that has to be a fairly erratic ride. With the rise of these options, scaling out a number of opportunities here, I think what we give folks the opportunity to do is get snacks, like bite-size experiences that help guide them to where they're going to be able to master the basics, to provide care in a top of license capacity with a greater degree of efficacy over time. And so one thing that's exciting for me is that as we have this variety of models, as we're making investments across systems, what we're also providing is a fair bit of career exposure that hasn't been possible in quite the same light as it is now historically. I think that to that end, the future is an incredibly bright. There are incredibly bright opportunities for the future. We've got a few minutes here. I'd like to take some of the questions that are in the channel, and then we'll round out with some closing thoughts, if that's good with all of you. One of the questions that we've got is, how can other healthcare leaders pivot their mindset to embrace contingent labor as a solution and not a problem? Mark, do you want to share some thoughts on this one first, and then Katie and Sheila?
We've worked really hard in our health system to really focus on having a balance. We believe that contingent workforce is necessary and it's very useful. At the same time, what we're really trying to make sure that we're doing is back to the brilliant of the basics, making sure that the various functions within the organization understand their data so that together we can share the story. From a human resources perspective, I really need to understand vacancy, open requisitions, our fill rates, so that I can understand how human resources is contributing to really efficient staffing. I need to trust the finance leader will be at the table to talk about volume, because if we feel like we're not staffed quite right, is it possible that it's a volume need or issue? And I need to be listening to the nurse leader who might tell me that if volume looks about stable and my HR metrics seem to look okay, that we're in a season right now where the average length of stay is a little bit longer. There's a different level of acuity that really necessitates the need to think about staffing differently. And Sheila, as you mentioned, if we do that frequently and stay ahead, we can look at those most appropriate price points for how we staff. And again, knowing that contingent is an appropriate price point under certain circumstances. During elective surgery season, which we're just about to enter now that everyone's hit their copay, it probably makes more sense for me to have a great contingent nurse or an on-demand nurse coming in and helping me with those procedures to care for the community and really to generate revenue. So we're making sure that we look at it and help our leaders understand there's a place for it. And again, as we've brought contingent workforce together in a platform, and we can manage rates together, we can understand utilization together, I think our leaders are understanding that we are wisely managing the investment. And ultimately, I think that's the key, is the demonstration that we're wisely managing the investment. So, but we are continuing to be really intentional. We don't call it a cost. It is an investment.
Yeah. Yeah, I think, Mark, you hit on one of the big topics. Ignoring the problem is not going to solve it. And very frequently there's a dictum that comes out and says, we will not use travelers, we will not use contingent, we're going to do this our own way. And that just doesn't work. And I think acknowledging that they are an integral part of your financial planning, budget for it. Too many hospitals I've seen, you get 6 months in and finance is yelling at nursing, you're over budget, you're spending too much money, because no one budgeted it. And so we need to acknowledge that this is a vital part of our nursing workforce, and we need to budget for it. So you don't have to keep defending. And then it behooves nursing to educate finance on the implications of the vacancy rate you talk about, or the turnover rate you talk about. There's the cost of orienting and everything else, which frankly, I've had some CFOs tell me that's fluffy dollars. But there is a cost to a patient fall. There is a cost to not getting your value-based purchasing from Medicare. There is a cost to not getting your commercial insurance incentives for quality. Those have real dollars to them. And if the nursing staff know what those dollars are, go to finance. How much money did we make from that commercial insurer based on our quality? Did we make 1 million, 5 million? What did we do? And what happens if we don't meet it? How much are we going to lose? So bringing that together, I think, helps. But integrating the whole process and acknowledging that this is a vital part of our staffing is key to our success.
Yeah, contingent workforce investment is typically a symptom of something else that we need to be addressing.
Very true.
And it all comes back to that workforce planning and ensuring that we're sitting at that table when we're preparing those budgets and saying this unit always has a high vacancy due to it's a stepping stone. We have people that are going to MP school and they're all going to graduate out in June. So we're going to have a vacancy of 6 spots in this. And so we know we're going to not have enough GNs to come in and support that. So we need to allot 13 weeks until we can get people out of orientation and up and running within this unit. And so really it is looking at all of those buckets of your pipelines and where can you fill in, but then where are you going to have to supplement? And so really looking at that supplemental labor as an investment, whether it's that PRN on-demand workforce and or that long-term, 13-week contract individual that you need to fill those gaps, and supporting the volumes that you're seeing throughout the year. And so it's a really important exercise.
Yeah, the greatest teams that we see on this, one key difference, you've all spoken well about anchoring on the idea of providing the best patient care as the pillar of these discussions, and then circling folks and teams around that. The other piece that once you get to that point as a team, the other piece that we see as a differentiator in the conversations that we have is where teams start to think about this as iterative experimentation. When you talk about it not as a fluffy dollar bat that you can financially beat one another with, as Sheila so eloquently stated, and more about the idea of here's what's working and here's what isn't, here's the tool set that we have. The discussion seems to enable that type of a discussion seems to enable progress much more effectively across organizations. And I think what gives me hope about this, Mark, you talk about it being us treating symptoms. We have certainly proven in a number of cases across the industry where we can do this in a clinical capacity, where we can help a patient solve for a root disease rather than attack the symptoms. When it comes to operational and logistical sickness, I certainly think we have the capacity to get there as well, in light of the clinical examples. We've got another question here. What does success look like when you turn to contingent labor to fill last minute needs? What happens? What does success, or how do you measure success when you send stuff to Nursa? Katie, you've got some pretty near-term experiences with this.
I mean, ultimately is really partnering with those nurse managers, nurse directors, and ensuring that we're looking at that hierarchy of needs and ensuring that we're putting those shifts out there, to your point, Curtis, early, so we can get those needs filled. And so really looking at the cost of labor, and what I've found through my own experience is that many times paying that overtime and incentive is higher than bringing in an on-demand worker to be able to support that unit. And many times on-demand workers come in and they're a part of the culture, they're a part of the community of those units, because they find the units that they really fit into and that they keep coming back to. And so really that has been some of the huge successes. And then multiple conversions of those staff that you mentioned earlier, Curtis, that the individuals become so ingrained in the culture and they are really enjoying it. And so then they just are like, I want to be a part of this team full-time or part-time, or even joining PRN programs at different health systems. And so really have seen a lot of success of those on-demand partners filling needs. And it's those last-minute needs of somebody's off on FMLA tomorrow. How do we get these shifts filled? The PRN on-demand workforce has been excellent for that.
It's a great commentary. Sheila and Mark, anything that you'd add to the thoughts here?
Honestly, I think success to me is when the staff on the unit welcome in the contingent staff force. In the days when we had all these travelers, you'd listen to a lot of problems about, well, they're making twice the salary I'm making and we're doing the same work. But when the staff on the unit welcome them in and say, oh, thank goodness you were available because now we have a better, safer staffing pattern for this shift, that's success to me. When the staff look at them as helpers and not the enemy.
Mm-hmm. Mark, anything else you'd add?
I would just add, along the lines of what you both said, when our patients believe this is the care team that is entrusted to meet their needs, we've succeeded.
Yeah, it's a great note. We often will see contingent priced different on a weekday or a weekend. And one of the things that we love to tackle in our discussions here is the concept that filling shifts on either Saturday or Sunday is harder. There are differences in how that happens. And so providing our partners with the lowest cost, reliable way to accomplish that patient care perspective on every shift is a part of why we think the future is bright. Being able to get the right fit every time at the lowest cost possible is an exceptional part of where we continue to see success on the facility side. And then you've covered how this looks when people come back. That's the best way to be able to demonstrate success and the patients are cared for. We've got time for maybe one more question and then just some final thoughts from each of you. Has anyone had success with implementing an on-demand workforce pool or an on-demand partner? Sheila, you probably have the most near-term experience with this, and then any thoughts that Mark and Katie would offer.
Yeah, I do think I think with the things we've already talked about to implement the on-demand, making sure you don't have exclusivity, making sure there's a large pool. I think one of the main questions I would ask any contingent workforce company coming in is, what is your pool now? To make sure that they have enough people in their pool to staff your needs. So that to me is important. And I do think making sure that your orientation and your onboarding of these staff is very good, right?
Mhm.
And so that to me is key. Again, making sure that your own staff know why you're doing this. I've been seeing situations where the per diem staff that you currently have are like, wait a minute, you're going to take our jobs away from us. And I think, Katie, you talked about it. How do you open up the schedule? You open up to your own staff, to your own per diem staff, and then out to contingent. And how do you do that so that everybody feels they had a chance to bid for those shifts? And if they don't want those shifts, now you keep going down the line. And I think that's important in making sure that your staff is on board of the reasons you're doing this. And it's not to replace them. It is to supplement them and to help them.
Right, I agree, Sheila. We have used on-demand workforce. It's been very successful for us. We also look at it as an option for staffing. And so where we've been really clear that it's a leader option, we found a lot of success. We trust the leaders and we believe they'll make good decisions. And as you mentioned, as we introduce on-demand to a nursing unit, we make sure that we're really clear with the unit why we're doing it. And we really try to reinforce with this as well, that these are individuals who live in the community. They're choosing to come here because of the reputation that we've established. They know the community, they know the level of care that we provide. We've precepted, we're confident that they can provide that level of care. So it creates a familiarity. And because of what we've seen with on-demand workforce, knowing that individuals come back multiple shifts, it creates a level of comfort as well, knowing that this really is someone who is committed to the care team, even if they're working in a non-traditional way.
And I think ensuring the integration is there up front. So ensuring that integration is present and that it is seamless across the board for nurse managers, directors as they're dealing with staffing. And then really looking at and partnering with your compliance and education team, as Sheila stated, and ensuring that onboarding is streamlined, sufficient, but streamlined, and that as short as possible, because these nurses are experienced nurses, and let's get them in there to help support our staff.
Yeah, treating folks with the expectation that they one day could work here, regardless of where they come from in the source, is a simple yet incredibly effective mechanism that I've seen each of you deploy in the work that you're doing. Okay, before we wrap, just as a note for final thoughts, anything that each of you would like to share before we close out and hand things back over to Maddie here. Katie, do you want to share anything as a final?
I think ultimately creating flexibility in roles and schedules will enhance the job satisfaction for our nurses, reducing burnout, helping with retention, and we know that it adds to the benefits of quality of care. And so I would just say, think outside of the box when you're thinking about these innovative care models or flexibility programs that you're building. Look at the different ways that you can supplement your staff and ask your workforce. They will tell you what they want and what they need.
It's fantastic. Mark and then Sheila.
This is a great opportunity in healthcare. There are more ways to work in healthcare than there probably ever have been, and embrace it. We've talked about a number of different things today that are options. You should trust yourself in your health system to make the decision that's best for you, and focus on the guiding principle that there are more ways to work. Embrace those new ways to work.
It's great. Thank you. And Sheila.
Yeah, I think Katie and Mark said it best. I think innovation's the key. Our goal is patient care. Our goal is staff satisfaction. I always tell nurses, happy nurses, happy patients. I'm a firm believer in that. Happy staff, happy patients. So I do think that flexibility, thinking out of the box, and remembering what our ultimate goal is to get there is important. And I think this whole concept of contingent workforce per diem, on a per diem basis is brilliant. And it was really an out of the box solution. And I think it's great. I think there's probably a lot other solutions out there too that could add to all of this. But I definitely think thinking out of the box, engaging the staff, shared governance to me is one of the most important factors in implementation of any new initiative and get buy-in and success.
Yeah, I think being able to look backwards and connect these dots is really valuable. It's very hard to connect them looking forward. And for each of you, as you look back, I'm so grateful for the positive thoughts and the ideas that you've expressed here. For anyone who's just beginning this journey, I'd just express a reminder that, the journey of 1,000 miles begins with a single step. And so much of the mechanism of how to accomplish this is with trust and experimentation among your team and for your specific context and nuance. We're grateful as well as we close out here just to be able to host a conversation like this in partnership with Becker's. And with that, Maddie, we'll turn the time back over to you.
Excellent. Well, that is all the time we have for today. So I want to thank Sheila, Caitlin, Mark, and Curtis for their insights, and Nursa for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us, and we hope you have a wonderful rest of your day.